Let's begin with the lecture Encephalitis Diagnosis, and in this first section we will talk about the CSF examination of the patient with encephalitis. In this section we will talk about the CSF profile, pleocytosis, and also CSF cell count and infections. Also, we will talk about red blood cell count and glucose concentration in the cerebrospinal fluid. And remember, in this lecture, we are talking about the diagnosis of encephalitis. So we will strictly limit our subject to the cerebrospinal fluid examination and what are the features associated with the encephalitis in the cerebrospinal fluid. So profile of the CSF, and CSF is the cerebrospinal fluid. It's the fluid that flows around the brain and the spinal cord. That's why the name is cerebrospinal fluid. So what's the profile of cerebrospinal fluid in patients with encephalitis? It's the contraindication. In contraindication, when the CSF profile, for CSF profile, we need to remove the cerebrospinal fluid with the lumbar puncture. And then first, what are the contraindications? What are the conditions in which we cannot remove the cerebrospinal fluid, or we cannot perform the lumbar puncture to remove the cerebrospinal fluid? Is if the increased intracranial pressure is present, then we should not remove the cerebrospinal fluid. It's contraindicated if the intracranial pressure is severely increased. CSF profile is indistinguishable from viral meningitis. So viral meningitis and viral encephalitis, profile of cerebrospinal fluid in both these conditions is the same. So they are indistinguishable. Lymphocytic pleocytosis is present, so increased number of the lymphocyte is present, lymphocytic pleocytosis. Mildly elevated protein concentration is present, normal glucose concentration is present. So these are some features of cerebrospinal fluid profile which are present in encephalitis. Lymphocytic pleocytosis, mild elevation of protein, not severe elevation or marked elevation. It's mild elevation, and normal glucose concentration is present. CSF pleocytosis occur in more than 95% of immunocompetent patients. Next, cerebrospinal fluid pleocytosis. Pleocytosis may be absent on the initial lumbar puncture. In this picture, you can see the lumbar puncture is being performed. The long needle, lumbar puncture needle is inserted, and then the fluid is removed. The patient is on the side with little bending, and then the needle is inserted between L3 and L4, and cerebrospinal fluid is removed. So on the initial lumbar puncture, when it is performed, firstly, usually the pleocytosis is absent. No CSF inflammatory response in patients with HIV infection, glucocorticoid or other immunosuppressant intake, chemotherapy, or lymphoreticular malignancies. So all these, in these conditions, inflammatory response is absent, no cerebrospinal fluid. Inflammatory response is present in patients who have HIV infection, patients who are taking glucocorticoid or other immunosuppressant agents, chemotherapeutic drugs, lymphoreticular malignancies. So in these conditions, no cerebrospinal fluid inflammatory response is present. And initially, in the initial phase, there is no pleocytosis also. CSF cell count exceed 500 per microliter and in 10% of the patients. So cerebrospinal fluid cell count is more than 500 in about 10% of the cases. Arboviruses and LCMV infection can lead to cell count more than 1,000. So if the cell count is more than 5,000, it gives the indication that it might be arbovirus and lymphocytic meningitis virus infection. Possibility of also non-viral infections if it is more than 1,000, and there is inflammatory processes also. The number of cells is more than 1,000 per microliter. So these are the few ideas about the cell count. In other infections, in other viral infections, besides arbovirus and LCMV infection, cell count exceed 500 per microliter, but in patients with the arbovirus LCMV infection, it's more than 1,000 also in inflammatory processes and in the non-viral infections. Next, the atypical lymphocytes. Atypical lymphocytes are present in Epstein-Barr virus infection. Atypical lymphocytosis is a typical feature of Epstein-Barr virus infection. Increased number of plasmacytoid molarate-like large mononuclear cells are present in West Nile virus encephalitis. So one by one, these are different features that are specific of certain viral infections. Atypical lymphocytes in Epstein-Barr virus infection. Then we have plasmacytoids, molarate-like large mononuclear cells are in the Western Nile virus encephalitis. Polymorphonuclear pleocytosis is in 45% of patients with Western Nile encephalitis, feature in cytomegalovirus myelorediculitis. Next, CSF neutrophilia. Increased number of neutrophils are present. Persisting CSF neutrophilia is indicative of bacterial infection. So neutrophilia is indication of bacterial infection, leptospirosis, amoebic infection, non-infectious processes, and acute hemorrhagic leukoencephalitis. So one by one, we now know CSF examination is very, very helpful in the diagnosis of what type of virus, which virus is involved, or whether it is viral or it's bacterial or leptospirosis or amoebic. So it tells us the causative agent if we do the examination of cerebrospinal fluid. Again, it also gives the number of red blood cells, significant number of red blood cells if present on the examination of cerebrospinal fluid, more than 500 count in non-traumatic TAP. Usually the pathologies that are associated with increased red blood cell, we have hemorrhagic encephalitis of type seen with herpes simplex virus. CSF red blood cell occur with similar frequency, same in those with non-herpetic focal encephalitis. So all these are the significance of red blood cell, the pathologies that are associated with increased number of red blood cell usually have because of hemorrhagic encephalitis or non-herpetic focal encephalitis. So these are the conditions associated with increased red blood cell count. Now, concentration of glucose is other important factor, examination factor. Decreased cerebrospinal fluid glucose concentration is distinctly unusual. Suggests possibility of, so it's unusual to have decreased concentration of glucose, but if it is present, it suggests bacterial, fungal meningitis, tuberculosis, and parasitic meningitis, leptospiral syphilitic meningitis, sarcoid or neoplastic meningitis, mumps, LCMV. So all these are the conditions. If you see, the viral meningitis won't have the decreased level of glucose. So if it is present, it indicates the bacterial infection, fungal, tuberculosis, parasitics, all different causes can cause decreased level, but it's usually not, it's distinctly unusual with other viral infections other than mumps and LCMV. So that concludes the section 1 of our lecture. Thank you for watching sqadia.com.